Let's kind of very quickly shift to this concept of lines of therapy. Tony, you already brought up earlier maintenance therapy. And just very quickly, I don't need a big discussion, is so 3 to 4 months of whatever your induction therapy is, and then what's maintenance look like for you?
So maintenance can look two ways. One is you always have a discussion about whether we give a holiday.
Total
which
holiday.
Is reasonable, less preferable, but it could be reasonable beyond a certain point. But maintenance therapy is preferable and primarily, has been shown to prolong disease-free survival, but perhaps even hint at survival.
A nudge of overall.
Yeah.
But what do you give? What do you do?
So I do capecitabine, so a la Cairo 3, but a little different. Capecitabine plus bevacizumab every 3 weeks. But capecitabine, in all frankness, to give it daily all the time for our patients, at least in the US, is an impossible task. So I've simplified it to 5 days, say Monday to Friday, because all the concerns that get raised about oral therapy and not try to confuse the patients about, you take it this and that. So say weekends off, Monday to Friday you take your pills, weekends off at a low dose.
I always joke if radiation doesn't work on the weekends, neither does chemotherapy.
Chemotherapy. Well, I mean, they need that, even that couple of days break in between the 5 days actually makes it reasonable.
I hear a lot of folks when I agree with what Tony just
that's
said.
That's your personal preference.
Yeah.
But John just agreed with it.
There's a couple of us, but what I hear a lot.
So it makes it more than personal.
From our community.
That is not in the literature.
From our community friends, they're, giving capecitabine can sometimes be an issue. Yeah. The copay is a barrier, this sort of thing, and so they tend to keep pumps going. Dustin, what's your strategy?
So I also tend to keep pumps going because I think the patients tolerate it better. When I do use capecitabine for a patient's preference, I actually prefer an every other week regimen of the capecitabine.
Yeah. Just chronic exposure, Mike, what are you doing?
Agreed. I mean, capecitabine where people would prefer an oral agent, intravenous, if that's
but you keep
working
maintaining it. Now, let's say it's a year. Kathy, I'll give you one vote
So
too.
I either do, it depends upon the patient, I either do IV 5FU or capecitabine, but with the capecitabine dosing, I'm very careful to evaluate the patient and see what I believe he can tolerate. I don't maximize the dose by any means, and I actually cap the dose at some point.
Well, always run down. I mean, that's the general rule with capecitabine, always run down.
Let me make it a year later. It's really going well. They've been coming in every 2 weeks, dutifully. You gave them 1 extra week off for summer vacation. Do you make any changes, or do you just let it ride? Do you keep both drugs going? Do you drop your Bev? What's just longer-term strategy? Because this does happen, right?
Yeah. So I actually, depending on the patient, this is where I start getting creative. Yeah. So, if this is a patient who now looks to have a really favorable biology, I start looking at their CAT scans a little different. Should I start thinking about, is this time to start whittling away at some things in the liver? Is this a time where maybe getting their primary out? Because at least in my experience, those patients who have the best benefit from bevacizumab-containing regimens are also the ones who seem to be at higher risk for perforation. So if you're going to be on Bev for a couple of years, that's probably something to consider, though not necessarily a standard that I would do for everybody.
Mike, let's shift gears a little bit to second line and beyond. I think of colorectal cancer and metastatic diseases like a chess game. And so, you make one move, then you have some other pieces on the board, and you decide when to move the other pieces. So I'm a little bit asking you, your overall chess strategy in deciding to move to second line and third line. What are some of the variables that you put in on it?
So in terms of choice of therapy, I'm sort of motivated by the idea of preserving as many lines of therapy for people. If we believe that the more lines you can receive, each of which have a couple of months or more survival benefit associated with them, the people might do the best longest. So I try not to discard drugs too early. So that would get into in the second line. If you give them bevacizumab first line, whether to continue bevacizumab, I'd definitely do that.
Well, so if we argued that at first line we needed to be more intensive initially, is that true in subsequent lines, or can I be a little gentler through second line?
No, I think there's going to be limitations, first of all, on what people can tolerate after they've already had a very aggressive chemotherapy approach. I don't think the data is as strong about giving aggressive therapy later on. I think you've chosen obviously a person that has progressive disease to the most aggressive therapy, it probably doesn't make sense to continue to be aggressive.
Kathy?
But the Tribe 2 did that, though. They reintroduced that.
They did, but you know, people.
I'm not saying that it applies to every patient.
Yeah,
but
no,
that data is there.
Well, I would argue that's a reintroduction and not technically a second line therapy. So I agree with you.
Okay.
I just want to make sure that we were clarifying that correctly.
Here's the
Yeah, I
other
agree.
point about Tribe 2, I think that's important to keep in mind. The majority of the patients were right-sided. The majority of the patients were RAS mutated. So again, that argument continues to hold for those patients where you think you're going to run out of options very quickly to intensify. For those patients actually who have more favorable outcomes, which is, you know, a good chunk of our patients, you don't need to go that intense.
But don't forget the original Tribe data had reported one of the highest 5-year overall survivals.
And it was
25%.
much lesser than CLGB 80405.
Yeah,
So
different
historically,
population.
I'm not convinced 100% that this applies to all patients, and I still think we really need to be selective.
Well, I fully agree with that.
Yeah.
I mean, we wouldn't give it, once again, as mentioned earlier by Mike, we wouldn't give it to everybody. But it's an option.
I agree.
But in the Tribe 2 study, it's important to look at, especially for this question about when we're reinitiating or going to second-line therapy, the triplet combination didn't have a better progression-free survival than just FOLFIRI-Bev did. And so, you know, coming back with the triplet regimen isn't necessarily better based on that Tribe 2 data.
Yeah. Just the idea of biologics beyond progression, I think we've talked about EGFR, but we do have, in all of the other patients, we have second-line indications for 3 VEGF inhibitors. Kathy, what do you do in this space in a patient that you want to continue on some VEGF therapy?
So in regards to refractory settings such as the
Second line,
multi-targeted.
second No, more in the, you have 3 monoclonal antibodies.
For the
that target
second line,
VEGF.
I think most of us traditionally do continue bevacizumab, as Mike mentioned earlier. I think most of us are comfortable with that. And obviously, some of the other drugs are a bit more costly financially, so that's another thing to take into account. I think historically, many of us will just continue bevacizumab.
Yeah, are there
if you
patients where you
initiate in the
might
first
change
line.
drugs in that setting? I mean, we see a lot of our community partners using the other
Oh, you do?
monoclonals, yeah, in
I
our
have not
space.
seen that.
There's not any reason, I mean, you can't compare the studies totally with each other because there's slight differences in the patient populations. In one study, they didn't all have bevacizumab in the first line, so I think it's certainly a choice of the oncologist and patient.